just going to plug my laptop in. It's like all neurologists, I brought videos which cause havoc with the AV personnel. And that's a fantastic introduction from Elsa. I'm going to expand upon that and really show you where we are in terms of using HIFU, so high-intensity focused ultrasound, for patients with movement disorders, but also expand upon the kind of general area of using this as an experimental tool to map structures in the brain like the thalamus. And it's always good to start off with a patient. This is a patient from the northeast of Scotland. And you can see this is a kind of typical disability that patients with essential tremor live with day in and day out. And thanks to the video editing of our external relations, you can see he's changed his shirt and had a miraculous improvement of his tremor. Now, this doesn't take seconds. It takes a couple of hours to perform this procedure, and there are lots of similarities to performing functional neurosurgery in the form of deep brain stimulation. The main dissimilarities, this is done awake, it's done as a day case, and the patient, as you can see, has got this rather unusual membrane which allows us to interface cold water which circulates around the patient's head and allows the ultrasound beams to actually transduce into the skull and allowing us to ultimately create the heat that we need to ablate the structures. Now, in contrast to LIFU, this is uncomfortable, this is not pleasant, but most patients tolerate this extremely well and have a marked improvement in their tremor. The beauty of this for clinicians, and I think part of the reason why it's become such a successful new modality for functional neurosurgery, is it's very clinically driven and it's really applied clinical skills. So this is the kind of typical workflow of one of our treatments. The patient starts off, we use Archimedes spirals to identify a baseline level of tremulousness. And as we build the energy within the target zone, within the motor thalamus, we start to see immediate effects at pre-ablative intensities, and then we turn up the energies and create a permanent ablation, an immediate effect for the patient. These patients are often very emotional by the end of the treatment. We've seen patients in tears. They haven't been able to write their name for decades. So it's a very beautiful operation to watch. And the technology under the bonnet is really kind of twofold problem. And Elsa's also already introduced this problem of the skull. And that's a formidable issue because of this heterogeneity between patients. This plot up here is actually an estimate of the skull density at each point at which the transducer hits the skull. And we have to switch off transducers that are simply not going to pass through the skull and create any form of heating. And the real magic of this system is the technology that allows us to align the phases of the waveform to coalesce at a single point in the brain to generate heat that ultimately destroys the tissue causing the symptom. And in combination with clinical assessment and this PRF thermometry, which is a specific type of MR sequence, we can acquire immediate information about the actual tissue temperature before we ablate it. And there are specific doses that we can deliver to create a permanent effect. It never ceases to amaze me. This is a bit like asking a psychiatrist to pin the tail on a donkey, I've realized. But this is a post-op scan of a thalamotomy. And there's a tiny little hyperintensity, which is where we destroyed the tissue 6 months later in that same patient that I showed you that video. Now, fortunately, I've colored it in for you. And it's a tiny volume. It never ceases to amaze me. You can do without this tissue and function perfectly normally. In fact, function better than you did before this operation. That is the paradox of functional neurosurgery. Of course, it's a function of destroying this pathway that maps through the motor thalamus, also known as the ventral intermediate nucleus. It's a pathway between the cerebellum and the motor cortex, which ultimately creates the tremor. Now, when we started out doing this as a fairly green consultant neurologist, the insecurity that one has, is anybody going to refer any patients to me? I had a few patients, but Fortunately, patients have really got behind this, and referrers around Scotland have also given us a huge amount of trust in adoption of this new technology. And we've treated over 100 patients over the last 4.5 years. Not all of these patients have a brilliant outcome in terms of improvement of tremor. It doesn't always work. It's often related to the skull properties, as we've already alluded to. So we have done retreatments. We have referred people for what I call DBS rescue therapy, but the majority of people are pretty happy. I'm going to talk shortly about the Parkinson's experience, which is really in a research context. And the effect, as I say, is a little bit, there's a sort of regression to the mean effect of this treatment. The average improvement is about 50% in terms of the objective tremor score. So the CRST score is a standardized rating scale for improvement in tremor. But actually what the true story is, there are probably people who are kind of super responders, and there is a subgroup of people who just don't really get a good improvement in function. And this converts to quality of life improvement in terms of the CRST Part C, which is an ADL score. Overall, most patients see an improvement in the majority of cases, but not everybody. We do have a subgroup of patients who we don't quite get a sufficient volume of tissue ablated. The side effect profile in our hands has been extremely good. The vast majority of side effects are transient, are really driven by swelling around the target site, so lesional edema or perilesional edema that's caused by the ultrasound. And only in one case have we had a significant, what I describe as an adverse event in a patient that, with hindsight, probably didn't have the brain reserve. He had serious cerebrovascular disease and had an extension of his lesion about a week after the procedure, which left him with a plegic limb. But the vast majority of these patients, at 1 year, if they have permanent side effects, they're relatively mild and subjective. So one of the learning curves that we've had, and I was thinking about this slide in the context of a talk that I went to in Spain, and there was a neurosurgeon stood up with lots of pictures of sniper rifles, and I thought, I'm not going to use that analogy right now, but targeting is really key. It's a critical question of delivering the thermal dose on the optimal piece of the anatomy, and this analysis that we did in a normalized template space showed us that we were probably placing our lesions too posteriorly within the thalamus over the first 30 cases. And we've adopted our clinical routine from standard so-called indirect targeting, where you measure the anatomical landmarks visually, to more direct approaches, so using specialist sequences which improve the intrathalamic nuclear contrast and using probabilistic tractography and segmentation to really delineate that individual variation in anatomy to improve the outcomes. Probably the single most important thing that we've learned is actually understanding the thermal dose-volume relationship. We can use information from that thermometry to precisely delineate the size of the lesion on the day. The challenge we have, and the whole field has, is we don't actually know how big that lesion needs to be. Clearly, big lesions lead to side effects, but small lesions lead to tremor recurrence. So there's ongoing questions about validating that question. So briefly, I was going to talk about our experience of Parkinson's disease. And actually, you're the first people to see the results of this, so you should be very, very honoured. I haven't shown it to neurologists yet. And this is a very simple study. It was really a safety and efficacy study. It's completely unblinded, and so you can draw whatever conclusions you want to from this. But for us, it was really about getting confidence that we could treat patients with Parkinson's disease. These were highly selected patients with very tremulous, almost monomelic tremors. This is a patient pre-operatively, and this is his post-operative video. And he's got a classical re-emergent tremor, particularly of his dominant right upper limb. And overall, the safety profile is very similar to essential tremor, and the efficacy is a bit of an unknown at the moment. We've only got 2 patients at a 1-year follow-up time point, so we're watching carefully for reoccurrence. But actually, initial results are looking pretty promising, and I think we will probably see that licensed in the next couple of years for tremor-dominant Parkinson's disease. Of course, Parkinson's disease is not a pure motor syndrome, and most of the syndromes or symptoms of Parkinson's disease which have the most impact are actually the non-motor symptoms, and particularly apathy. And although we've got lots of potential targets for treating motor symptoms in Parkinson's, we have no real approach to deal with symptoms like apathy. This has kind of stimulated a lot of work in my group to try and take techniques. I'm a bit like a kind of magpie. I take bits from cognitive neuroscience and apply them to my patients. And this is a picture of Kelvin Grove Academy in Glasgow. For the Glaswegians in the audience, Glasgow was voted third most exciting city in the Time Out review this year, third to London. But you or I, when we see this scene, it's obviously there's huge opportunity in that scene. And if you're naive to a place like Glasgow, there's an invariable process of interacting with that perceptual environment and interacting it through exploring the options and potentially exploiting that learnt experience to maximize the hedonic pleasure you might experience from that interaction with the environment. And in effect, this is a well-trodden path for people who are cognitive neuroscientists who study value-based encoding in the brain. And with this kind of concept in mind, in my lab, what we've been studying in Parkinson's disease is this classic task called the restless bandit. And it involves effectively playing a kind of stock market gambling game. It was made famous by Nathaniel Dorr in the early noughties. And in effect, what the patients have to do is try and identify initially at random one of 4 slot machines which might have the highest potential points payout. With each trial, they're given feedback between 0 and 100 points. But the tricky thing about this task is that the payout is conforming to a thing called a Gaussian walk, which is a constantly fluctuating payout schedule, a bit like the stock market. That's hidden from the patient, so they have to constantly fluctuate between exploiting information that they have from the experience of the previous choices and then exploring other options. So we studied this in Parkinson's patients from my clinic who had clinically significant apathy and patients who were non-apathetic. And one of the key features or the kind of decision signatures in people who are apathetic with Parkinson's disease is that they're highly sticky or non-sticky in their decision making. They're constantly finding the best option, but they invariably try and look at the other options, the non-optimal choice in that task. And that's fundamentally different to the way that somebody with Parkinson's disease who doesn't have apathy plays this particular game. If we use computational modeling, we can kind of take this a little bit further by mapping this across the explore-exploit kind of conundrum. And invariably, patients with apathy are unable to exploit the value of their learnt experience and explore low-value options without returning to the optimal choice. So this shift towards exploration in the absence of exploitation is generally very predictive of individual apathy scores. And we're very fortunate enough to bring patients back and scan them using fMRI, using event-related fMRI. The variety of different results from this study, but one of the surprising ones was that patients without clinically significant apathy, when they were finding the best bandit and exploiting that information, they were substantially deactivating large parts of their brain, including the thalamus. So we're coming back to the thalamus. When we did a between-group contrast, it was this deactivation of the thalamus that actually was very pronounced in the non-apathetic patients. This led us to think that potentially there was some compensatory mechanism that was retaining their ability to perform the task in the non-apathetic Parkinson's brain and potentially retaining motivation. So go back to that patient I showed you at the very beginning of the talk. And this, I didn't show you, this is the thalamotomy edema immediately 24 hours after his operation. So it builds up, and that's why we get side effects of this operation. And obviously the primary center of this edema is the motor thalamus, but it also encroaches medially on really fascinating structures which are very poorly understood, including the medial dorsal nucleus, which has reciprocal connectivity with the prefrontal cortex, those circuits which are critical to encoding and using value estimates in that task. So a natural extension of that work was to take people who had a central tremor and look at the effects of thalamotomy edema on the bandit task. So we tested them prospectively before and after a thalamotomy, and we were fortunate enough to have a control group in Liverpool. So our colleagues in Liverpool also do this operation, and they tend to scan their patients immediately after their thalamotomy. So we tested them immediately after the thalamotomy before there was any edema that might cause that medial dorsal sort of engorgement. And we compared their performance in the task in patients who we delayed the testing in till 24 hours after their thalamotomy, which was maximal for this vasogenic edema. And remarkably, what we managed to show in this study was that we could actually flip behavior in this task to the opposite to what we see in Parkinson's apathy. So patients, albeit with essential tremor, who had a thalamotomy, 24 hours after they had their procedure, became very sticky in their choices, and they were very exploitative, and they minimized their levels of exploration. So we've been quite excited about this because potentially there might be an avenue here to start thinking about using the medial dorsal nucleus or the thalamus as a potentially route into treating motivation in Parkinson's disease. The challenge here is understanding exactly where this effect is mediated, and this is a fairly complex statistical analysis by looking at how each voxel contributes to that behavior using a linear model where we weight the voxel's importance to predict the behavior. It was actually only in the medial dorsal nucleus that when edema spread into that nucleus could we show that it actually predicted this change in behavior. In the other thalamic nuclei, after we'd segmented and pre-processed the individual anatomy, there was no predictive value of whether the edema encroached into that part of the thalamus. So the current work in progress for us is to kind of resolve or more precisely understand whether this structure may be a potential route in to treat apathy in Parkinson's disease. And I go back to this idea from earlier on in the talk, which is we use sublesional doses of ultrasound to neuromodulate the motor thalamus. And spiral writing is a good example of the outcome that we use to measure whether we're hitting the target. And by extension, what we've started to do is intraoperative testing. So this is us with a family iPad that was donated for the research program, and a touchscreen version of the Bandit. And so we deliver a non-lesional dose to the medial dorsal nucleus and see whether we can perturb decision-making in that task using the offline effects of heat. Now, these are not permanent lesions. The effect is looking pretty transient and is a work in progress in terms of the analysis. The other challenge with this approach, although as Elsa's been describing, this is highly spatially resolved, we can deliver very, very small spatially resolved doses of ultrasound to this structure. The dose relationship is highly variable. So the take-home from this slide is that the dose, which is called a CEM, a cumulative equivalent minute dose, is highly variable. So we've got one patient here, we delivered 13.9, we're delivering 0.01 with the same parameters. So there's big problems in terms of the variance of using this thermal neuromodulation approach to map the thalamus during a neurosurgical procedure. So I'm going to stop there and just kind of summarize what we've discussed. So apathy and Parkinson's disease, you can map that to this explore-exploit kind of problem. And patients without apathy, if you study them in that same task, they appear to suppress activity in their thalamus, suggesting some form of compensatory mechanism. And in essential tremor patients, we can shift that explore-exploit tendency in a reward learning task, which might suggest that there's a route in to mapping that structure, which we think is probably mediated by the medial dorsal nucleus as a route to therapy using functional neurosurgery for apathy. And this is kind of where we're at. We're very interested in Elsa's work in terms of using low-intensity focused ultrasound to characterize that structure further in Parkinson's patients. Potentially, if you could find the right surgeon, it would be feasible to reversibly neuromodulate that structure with DBS in a patient who was already undergoing ST and DBS. And I think we're a long way off, given the potential controversy of lesioning for psychosurgery indications, like a HIFU treatment, but that ultimately I think needs to be the big question of this field. Okay, thank you very much, and very happy to answer any questions.
Thank you, that was absolutely brilliant. So we've got time for questions. Yeah, Rich.
So I actually have two slightly related questions. Okay. So the first was in the essential tremor, you mentioned there's sort of most people respond quite well.
Yeah.
There's people who don't. Is that, do you think, because of patient factors and kind of patient selection,
Yeah.
abnormalities, or only due to the
No,
procedural factors?
I always blame the patient for the failure of my treatments. No, there's several factors there that, as we alluded to earlier, I think it's mainly about the skull, and the problem with the patients who've got particularly low skull density is the ultrasound is absorbed by the marrow, so you have to deliver very high energies to get any thermal dose into the target zone. That's very painful. It also causes kind of nausea and often leads to kind of termination of the treatment before you can actually ablate a reasonable zone. So the skull is the biggest factor. There are clinical, I think, phenotypic reasons why we see failure. So there are people with dystonic tremor that I think are really difficult to treat. I think the target that we go after, the VIM, is probably not the best target for all tremor phenotypes. It's great if you've got a pure ET phenotype, but not for more complex tremor.
And then I guess the related question was, when you were then explaining how you were looking at lesion expansion to affect the more kind of cognitive aspects, did you do that in the patients whose tremor didn't get better, and did that correlate to their apathy?
So we haven't.
Really in that group?
No, we haven't. We're really looking, if you like, at the collateral effects of targeting the motor structure. Although we have studied a small number of PD patients in the same task who were having a thalamotomy for tremor control, and a couple of those were apathetic. And we did see a restoration of reward sensitivity in those patients, but it's literally 5 or 6 patients. So we've got work to go on that pilot. Yeah.
Brilliant. Thank you.
Okay.
Just behind you.
Hi, thank you. So interesting. I also have 2 questions. So the first would be, do you think there are some advances to multi-site approaches? And the second would be, in psychiatric disorders, coming from a little bit of DBS treatment with patients, we see a later response sometimes to some psychiatric problems, and then also they tend to shift, or they change over time. Do you think there are some compensatory mechanisms as well when we have this lesions involved, and should we actually approach more the lesional approach, or more maybe the low intensity approaches with psychiatric disorders?
Yeah, I think so. In terms of, when you talk about multi-site, I'm assuming kind of lesioning both sides, or kind of multiple different targets?
Within a network, maybe?
I think the conceptually it kind of would make some sense, but it does come with risk. The more lesion and the bigger lesion volume you create, so taking the standard example, which is bilateral, essential tremor is a bilateral condition, and we don't currently do bilateral stage thalamotomy because of the risk of causing side effects that are permanent. That's really an extrapolation from the old days of pre-DBS, where people would use radiofrequency ablation and had horrific problems with balance and dysarthria. So the kind of bilateral lesioning approach raises the problem of whether the brain can compensate for that, in terms of interhemispheric bilateral treatments. There are groups in Spain who are lesioning multiple parts of the basal ganglia, so subthalamic nucleus, palatothalamic tract. And that's been controversial to a degree because of the side effect profile of hemibalism is potentially not inconsequential there. So the answer is you can, but it comes with risk. And I think the key thing is to do this in a safe and somewhat pedestrian way initially. Okay.
Is there a seizure risk?
As far as we have not seen any seizure problems related to it. I think if you scoured the literature, there probably has been some case reports of seizure. We have treated people with well-controlled epilepsy without any issues. So yeah, I think the seizure risk is low. It's about energy delivered. There has been 2 case reports of intracranial hemorrhage from patients having thalamotomy, and those procedures were delivered using energies that were gargantuan in terms of creating cavitation, which is, I think, a serious complication if you drive up the energy too high. So it has to, this is a very sophisticated bit of equipment, but it's potentially, without due clinical diligence, it's actually quite a dangerous device.
Boyd.
Thank you. Hopefully you're coming tonight because I've got some other questions as well, but I'll do them tonight. The question, as we've moved on to practicalities, I presume that the patients who would benefit most from an ultrasound thalamotomy for Parkinson's disease would be the younger people with a tremor. But those are also the people who later on might benefit most from DBS and some other advanced therapies. So do you envisage in the future a MDT where you say, well, actually, we're not going to do thalamotomy now, do DBS, even though they've only got a tremor, because actually they may benefit more from other treatments? Or how do you see that field?
Yeah, it's a recurring theme of our MDT, actually, that kind of conundrum. And obviously, the first problem is practically you can't have a thalamotomy with ultrasound after you've had DBS because of the incompatibility of the DBS hardware with the MR. So you can't do it that way. I think taking PD, we've got relatively little experience. The patients we've treated have been older, actually. They've been very, very much that kind of tremor-dominant, non-akinetic rigid group. And I think my own view is that the current target that we've got is very limited in the younger patients who've got tremor but have got a broader set of motor symptoms. I think they should be having DBS before this. In younger patients with essential tremor, though, I've got a different view on that, and I actually think this is potentially a kind of DBS delaying procedure for that patient group. We've had some younger patients who are really quite disabled who have opted for this because of lifestyle-related factors, so people working offshore, and it's been a great success. And actually, the last thing they need at that point in their life was hardware implanted, and even if the effect, kind of delays, tapers off after a few years, I think MRG first, then DBS is a reasonable kind of order.